It's my distinct honor to introduce him. The honor is distinct because not very many people get to introduce him. He keeps a low profile, Dr. Levi. Actually, again, I believe in introductions. I think the standard way to introduce someone is to read their CV or whatever you find on their website or marketing materials. And I urge you to go and look all of our speakers up, because it's sort of unfair to them to try and summarize in 60 seconds or 120 seconds how truly accomplished they are. I will tell you that Dan is an associate professor in the David Geffen School of Medicine at UCLA. He's a pediatrician. He trained in pediatrics and then did his fellowship training in pediatric cardiology and interventional cardiology. He's a director of the Pediatric Interventional Cardiology Fellowship. He's the director of the Pediatric Interventional Cardiology Catheter Laboratory. He's been NIH funded for the past decade, and is a pretty impressive figure in this field, and really is the go-to guy at UCLA for some of the most complicated congenital heart disease presentations that we see in kids. So to all that I say whatever, because this is the Dan Levi I know. So Dan and I went to school together. I've known Dan Levi for 25 years, or thereabouts, right? This was, yes, that is me. I lost weight and Dan sort of picked some of it up. This is our freshman year at the Pi Phi Sigma Chi winter Winter of Love party. Dan was a Sigma Chi, I was a Phi Delta. We both dated Pi Phis. And this is how our relationship started. And then what you see is what you get. I feel that people don't change fundamentally, and you can tell a lot from a person's face and a person's eyes. And the same sort of sense of excitement and joie de vivre and enthusiasm that you see in Dan as an 18-year-old, you'll still see today if you're his patient or his patient's parents or his colleague or his friend. And it's great for me that 25 years later we end up, just by serendipity, working together as colleagues in the same institution. And it's really a joy for me to see him on a daily basis. And we still will have a beer every once in a while when our schedules permit. So, without further ado, I give you
It's usually wine. And we weren't. I think that was probably apple juice that we were drinking. The Pi Phis would serve apple juice.
Yeah.
It's great seeing Reza every day. I was actually very scared of Reza when I first got to Stanford, because he was the cool guy with this really long hair. And I was very intimidated by him. I just stayed away from him. I thought he must be a really mean dude. All the women loved him. So, and then he ended up in my class. I go, wow, this guy's a really nice guy, actually. I shouldn't have stereotyped him into the mean, long-haired guy, just because all the women loved him. And we always do disclosures. I'm so sorry to have to leap up in the schedule, but they're going to kill me if I don't get back to the hospital. We always talk about disclosures. My disclosures are, I do have a relationship with some of the device companies that give us devices to go to Peru with, and I'll show you those. In this case, those disclosures are, I think, beneficial. And the other real disclosures, I'm going to be talking about Hearts with Hope, or Corazones con Esperanza, and that's an organization that I'm just a small part of. So everything I say here, I take very little credit for. So essentially, our organization started out just being missions to treat kids with congenital heart disease in Latin America. Now our mission statement is broadened to a humanitarian mission statement and a dental mission statement. And as I go through some of these pictures, I'll feature some of these pictures. Some of the people, this is Swati Patel. If we haven't had her, have you had her talk? She's unbelievable. Anytime she gets a day off from UCLA as a head of pediatric anesthesiology, she is in the third world. I mean, what are you doing for your vacation? Oh, I'm going on Op Smile. All right. She's been on every one of our missions. So every single one of her vacation days is spent on these missions. And anesthesia, for any of the surgical or interventional missions, is just a huge thing. So how did this sort of come about? Well, two things happened. Number one of my partners, Dr. Juan Alejos, is from Peru. So that sort of, being a pediatric cardiologist from Peru, he wanted to give back. But, and I'm not going to bore you with these slides, but what this slide basically says is there is a lot of people in South America. And this is an old slide. There's well over 200 million people in Brazil now. There are a lot of kids being born with congenital heart disease, and very few of those kids are getting operated on. So there is a huge need in a lot of all parts of the world. I hate the term third world, but specifically in South America and Africa, the two places that I've been, most kids with congenital heart disease are not getting anywhere near the care they need, and most of them are dying. To summarize the last slide, Brazil is getting better and better. Chile is becoming very advanced, but we've chosen to focus on Ecuador and Peru, which along with those two companies, along with Bolivia and Paraguay, are really fallen way behind in terms of caring with children born with heart problems. And listening to the last speaker, it became the different diseases are very different. The one nice thing about cardiology that maybe drew me into it is, hey, you can fix somebody's heart, and with some forms of heart disease, you fix their heart, you close a hole in their heart, they're cured, you're done. No insulin injections for the rest of your life. So in some ways, that's a very nice thing about cardiology versus a lot of the other types of medicine. Now, some of the kids, it's not like that, but there is an opportunity in cardiology to be able to do one curative procedure and actually fix the problem for life in some cases. In South America, the numbers I showed you are probably underreported. There's, we see all sorts of kids coming from the rainforests and mountains in Peru, and there's a huge failure to just diagnose these kids. So I don't even think we understand how much of the problem there is. In Africa, when I went there, they just go, well, in some countries in Africa, they go, well, we don't see these kids with congenital heart disease. Well, yeah, because you don't know how to look for them. And a lot of them, they go, well, the kid was blue and died, so it's probably a form of single ventricle heart disease or pulmonary atresia. So there's probably, the scope of this problem is underappreciated and underreported. And why? Well, a big part of it is training. There's not pediatric cardiologists. There's insufficient equipment. And, frankly, there's much bigger problems in a lot of parts of the world. This isn't, in pediatrics, congenital heart disease is a fairly large problem, but in the grand scope of medicine, it's a fairly niche thing. And in a lot of parts of the world, there's just much more prevalent diseases that, when you're triaging what you're going to focus on, a lot of times congenital heart disease is a little bit further down the ladder. And, why diagnose it if you can't treat it? If you're not going to be able to treat it, there's maybe not as much of a reason to diagnose it. So I think that, in the continents that I focused on, specifically Africa and South America, there's a huge opportunity to make a difference here. Of course, the problem is, doing an open heart surgery or even doing an interventional cath isn't always, something you can do out of a van or just fly in and do. So our focus has been to start with one city, and we picked Arequipa, Peru. Arequipa's, anybody ever heard of Arequipa? It's a really cool city. It's a white town. I love this. We're going to bring Reza there. I love this city. A fun city, fun nightlife for the frat boys like Reza. But a beautiful city way out in the middle of nowhere, and it's got 1 million people there, and they have just enough. So we need something there. We can't just go into the Sahara Desert and start doing heart surgery. We need a hospital that has basic ORs and a basic fluoroscopic unit to do interventional cath, and that's what we found in Arequipa. There's almost 1 million people there now. It's pretty high high enough that sometimes you have to take Diamox. We found a couple of hospitals interested in hosting us, and we've sort of adopted 14 orphanages. It's just a huge orphan problem in Peru as well. These are pictures of Arequipa. It's such a cool city. Look at this. They have this massive volcano covered in snow, and this is a view from the hospital. You just see, this is a view from the hospital at night. And when we first started going there, the mountain there, this big volcano, was covered in snow. In the past 11 years I've been going there, there's no more snow on the mountain. So I'm pretty sure that global warming may be real. I'm not sure, but it's like, are you kidding me? There's no more snow in this mountain. It's not like we're going during different times of the year. We're going at the same time. So global warming probably is real. Okay. And when you think of Peru, a lot of people in rural Peru, this is what you think of. But this is what a lot of the towns look like. It's an amazing country where they'll just, they don't have some of the regulations we do. They'll put some water and basic electricity and water in part of the desert, and all of a sudden everybody will just start building houses there. And it's a huge portion of the population without health care, and probably, we've chosen to focus on congenital heart disease, but probably you could focus on a lot of different pediatric ailments. And there are eye doctors that go, and OpSmile goes to Arequipa, Peru, on these missions. It's a really cool airport that you fly into, and you get off your plane in the middle of all these mountains. And then they've done something for me that's really great. They greet me with a sign, but they always position the welcome sign right underneath the advertisement for the beer there. That is Arequipeña. So in Arequipa, it's Arequipeña. In Cusco, it's Cusqueña. But very good beer, actually. And that makes me happy. So, what do you really need to make a mission like this successful? Again, you can't just fly in and go, hey, we're here, we're going to operate on all your children, So what we've done is we found a place, and there's a lot of places like this, where we could team up with the doctors there. There's no sense doing this if you don't have a team of doctors and nurses and volunteers in the place you're going that you can work with. That's the only way to really accomplish something and make it sustainable. We've started something called Cardio Salud that a doctor named Pedro Torres started. And FISAL is sort of a hospital organization, and it's been 10 years. We made a commitment. We said we're going to come back every year and we're going to make this work. So we're not just coming one time. We're going to go back every year, and I've been back every single year to the same place, which I'd rather go like a bunch of different places personally, but this is what you have to do if you're going to make it work. To really make something work, you have to have a commitment to them if you're going to expect them to have a commitment to you. And I have interposed cute kid pictures of some of the patients we've treated in between my slides. So not only have we not only do you have to win the trust over of the people and doctors in the city or country that you're going to, but you have to win the trust over the government and the hospital, because guess what? There's politics everywhere. So you roll in there and you figure, oh yeah, we're just going to use these ORs and cath labs, but a lot of the other doctors get really upset. They go, I got to do a heart cath on this guy with a heart attack, or we need our ORs to do some other surgery. So you really have to be respectful of the politics that you're going into. We've actually approached essentially the health agency in Peru and said, look, we're coming, we're making this commitment, we're raising all this money in the United States, we're going to bring the top doctors and devices, and we've sort of made a pact with them that's allowed this to really work well. But if we hadn't done it in a political fashion, I think we would have hit some serious roadblocks. So it's not as simple as it seems. One of the there's not only political and politics at the government level and the hospital level, but there's also social things to think about. And it's one of the things that is amazing about going here is the people just bring us their kids. All they know is their kid has a heart problem here, just take them. It's like, you know what, let's talk a little bit. And I don't really speak Spanish that well. And they go, no, it's okay, just take them and fix them. And it's amazing how, I can't, and here, if the families in Beverly Hills, they got to talk to 10 doctors before, they can get a little thing. That just, that part of it's amazing. But there are some social things that you really have to understand and be respectful of. When I was a resident, I went to Africa and I saw all these babies being born to moms that were HIV positive, and the babies were then, 30, 40% of the time HIV positive. I said, oh, this is an easy fix. So I organized for a bunch of protease inhibitors to be sent over, and I gave them to the doctors. I go, here, I gave them to the OBs. I said, you can treat the moms now, and the babies won't have HIV. One dose of protease inhibitor, boom, no HIV. And this was a while back. And they said, oh, great, thank you very much. And then I followed up on it, and they go, oh, no, we just took it and we treated other patients. You know why they did that? Why didn't they want to treat the moms? Because they didn't want a huge orphan problem. They didn't want to prevent the kids from getting HIV, and it's like, that's just sickening. You think about that, that's just, how can you do that? But that's how it was. So you have to sort of, you can't just, you have all these great ideas, but sometimes the ideas don't work because of what's going on in the countries. Anyways, that's a little bit of an aside, but this is what we've done with congenital heart disease. We've done 4 missions now to Arequipa, 9 or 10 to Arequipa, 7 to Lima. We've started a mission to El Salvador, and we have plans to expand now into Cusco and several other potential sites in South America and Latin America. This is a little bit of an old slide, but as of last year, we've done almost, over 120 surgeries. This is probably about 140. We've done about 240 curative cardiac catheterizations now. So that's a lot of kids. And what we tend to have to pick the kids, and this is very difficult as well. We try to provide the same level of care, but we have to pick the kids that we can do one procedure, close a hole in the heart, and you're good. Okay, we can't do everything that we do here down there because some of the procedures require multiple surgeries in the same year, and we're just not there. And some of the surgeries have so much complexity that it's just too high risk to do over there. So we do have to cherry pick the cases that we can do easily, effectively, and save or greatly augment somebody's life. We can't do it all, which ends up being frustrating. And as I'll show you, what we realized very quickly is there's a huge dental problem there too. I mean, because the anesthesiologists were out intubating all these kids, and they go, their teeth are terrible. We got to bring some dentists down there. So now we have a massive dental outreach to go along with our congenital heart disease outreach and our humanitarian outreach. So these pictures just sort of show the process down there. When we get there, it's amazing. So our team of doctors on the ground has identified a handful of kids that they want us to perform procedures on. We've taught them how to identify the diseases. We've given them the equipment to identify the congenital heart disease. And then just people start coming out of the woodworks. They hear that we're coming, and any mom within, 500 miles, they'll take buses there and they'll say, evaluate my kid, I heard he has a heart problem. And a lot of these kids do have the kind of problems that we can fix, and some of them don't. But it's amazing. They just start lining up outside the hospital, mainly because mainly for the cardiac services. But of course, our team also has a huge humanitarian component that goes out to different orphanages and different schools every day with dentists, anesthesiologists, and general volunteers. So there's a huge range of opportunities, and general pediatricians, to volunteer with our organization, whether you're an anesthesiologist, a perfusionist, a OR nurse, a cardiac nurse, a dentist, a regular volunteer, just anybody interested in helping. We have slots for everybody, and our team's gotten massive. It's actually a little too big. We bring about 50 or 60 people down. The work that the dentists do is fantastic. This is Bill Sears. He had a heart transplant. He comes every year. And he brings these balls to give out to all the kids. We call them Bill's balls. And he's just fantastic. He's got a new lease on life. But we also screen all these kids. So as our teams go out to all these orphanages and schools, they actually identify kids that have heart problems, and some of them need to be fixed. This is Bree Bailey, who's beautiful. She goes on all these missions, and she's always bringing back like malaria and stuff. She's a bigwig at Lionsgate Entertainment. And that's Dr. Alejos, who really founded the founded this whole organization. And they screen the patients, and then we do echoes, and we figure out which patients we can fix. And we train the doctors there to do the echoes. That's Dr. Perrins, training one of the Peruvian sonographers. And then one of the places we'll bring them where I work is the cath lab. They have this very primitive fluoroscopic unit, but it works. And the two defects we fix most are basic holes in the heart. This is an atrial septal defect, and this is a basic angiogram. I'm going to fly through this, but essentially when we inject on the left side of the heart, you see dye going across to the right side of the heart. You can almost see 4 chambers of the heart on that x-ray, right? So we can plug these holes up by putting a catheter up. See that? Putting a catheter up into the heart, and then deploying these sort of self-expanding plugs. It's a relatively simple procedure to do. It takes, half an hour or so. So this is the kind of procedure we love. And when we are done with this, we'll push and pull on the device. It's called the Minnesota Wiggle. Make sure it's there. One of the things that everybody will tell you, especially with the heart disease, in which complications can be unforgiven. There you saw we released the device. You got to make sure you get it right. We can't tolerate having complications down there because we can bail ourselves out, but we have the limited ability. This angiogram shows that once that device is in place, you see now all the blood stays on the left side of the heart and the kids go out of heart failure. The other big thing that we found in Peru is they have these things called Pdas. It's a communication between the aorta and pulmonary artery that needs to be plugged up. And see, these videos aren't working now. But one of the this just simply shows a plug going into that. And this plug, the big challenge in the cath lab is actually getting these devices. These devices in the United States cost $3,000 to $6,000 a device. If we could blow our whole fundraising budget on these devices. So one of the things that I've done is approach companies that have devices approved outside of the United States that want to bring their device to the United States and go, hey, I want to learn to use your device. Give me a bunch of free devices, and I'm going to use them in Peru, and then I'll be your guy when you bring them to market in the United States. And it's actually, so these aren't like, and then people go, well, you're using non-FDA approved devices? Yeah, because they're approved everywhere else in the world, and the problem is not that they're bad devices, just that the FDA is so slow approving devices, and it's so expensive getting the devices approved here. So it's actually been a really neat thing for me personally, is I develop expertise on all the European devices in Peru, and then I help the companies bring them. So we've gotten a little creative about how we've gotten over that. Cath lab stuff is great, because you do a cath, you wake the kid up, and they can go home the same day or the next day, not like these surgeons who are, making these big incisions. And then, so this is what patients look like after we cath them. The hole in their heart's closed and they're good to go. So other than the cost of the devices, if you can get fluoroscopy, this is a great thing. Dr. Reemson spoke last year, and this is the open heart surgery is a big deal. And just trust me, these guys are way more talented than we are. Opening up these little babies and stopping the hearts. We have to have a full cardiopulmonary bypass unit there to suck the blood out of the hearts, oxygenate it while they're fixing the hearts. And this is, I won't play the movie because I don't think it's playing. This is what open heart surgery looks like. And this is one of the surgeons that goes with us, Dr. Mark Plunkett. And we've had no problem. The one thing we don't have a problem with is we have the best surgeons in the world coming down with us. The best surgeons in the world come with us. Oh yeah, we'll come. And by the way, all the volunteers that come, we don't have enough money to pay for their plane tickets. Everybody pays for their own plane tickets. Nobody ever says a word about it. It's just amazing. The problem with open heart surgery is once you put a patient on bypass and open up their chest, the recovery is a little bit more involved. You need a full ICU team, ventilators. In the OR, you need scrub techs, perfusionists, nurses that know how to run an OR, and you need cardiopulmonary bypass machines. So it's not. We go there with 60 massive duffel bags. You should see the airport. It's just amazing. But we basically aim to provide the same level of care to these kids here as we do here, and you end up MacGyvering a lot of stuff, and it's never perfect, but. We always do very well. There's Andy Medikians, who's a fantastic intensivist that always comes, and we've been remarkably successful about actually doing open heart surgery on, as you saw, over 120 kids in Latin America. And once they start waking up, they're really cute. Our basic goal is, teach a man to fish. We're trying, it's impossible with things like open heart surgery probably, but in the cath lab, we're trying to train the physicians to actually do the basic procedures. They scrub in with us. We have nurses working with nurses, perfusionists working with perfusionists, and really it's got to be a long-term effort, which we've made. I mentioned the politics and the equipment. One of the biggest problems we're having is because we've made this long-term commitment, they become reliant on us. So they go, we'll just wait till you come back and then you can close all the ASTs. We go, oh no, you guys should do a few. So there's a little bit of weaning that has to be done. We've had huge issues in customs. It's amazing. If you can't bring, all this stuff expires, and it's perfectly good stuff here. I mean, seriously, it is. I'm not, And so we used to just bring all the expired stuff down. That's perfectly good and still sterile, and then we'll re-sterilize down there. In customs, there's no more expired stuff. But if you take it out of the bag and re-sterilize it, then it's okay to go through customs. So there's all these little things that you learn. But really, we're never lacking volunteers. America's an amazing place, and a lot of these missions really speak to how great of a country we are and how many humanitarians are. There's never a problem in the United States getting volunteers like this guy to come down there and do whatever we need done. We're seeking a local sub-board and local donors, and it's been remarkably successful. Our mission's actually pretty awesome too, because Peru is a great place to visit. The floating Hoyos, Lake Titicaca, Machu Picchu, we go to the jungle. And again, we're expanding to probably Cambodia and Philippines. That's still in the works, but definitely Chiclayo and Cusco, as well as our missions to Arequipa, El Salvador, and Lima. And so it's really gotten massive, and we need everybody. And whoever you are, you can come with us, because we have a job for everybody, whether it's nurses, doctors, ICUs, and then different people come and they have different ideas. So one group of women came and they go, all these kids need dolls, so they sewed a bunch of dolls. Another woman came down and they go, oh my gosh, the shoes are so terrible. So now we bring all these shoes with us and we give away shoes. So, if Reza come and you go, oh, I got to fix all these cleft palates. Different people that come always bring different, always augment our mission with different things that they make or bring, or different skills that they bring to the table. And what I like about this organization is we're always open-minded to having anybody who wants to help us. And I'm going to stop there in the interest of time. Thank you very much. I think I had one question. A hand went up. That's good. Yeah, as a pre-med, we could put you in charge of the open heart stuff. You do have a good GPA. And that's why I was just telling Bonnie and Reza, I think all the pre-meds should get out here, because all these organizations are great opportunities for anybody interested in medicine. We've had undergrads, pre-meds, everybody come with us, and the best way I think to get involved is to you can go on our website and fill out the volunteer application, but if you really want to get involved, you call us up and you go, hey, I see you're having a fundraiser. Let me volunteer at your fundraiser and help you guys, so you do a little work over here, or let me clean some catheters for you. And then you go, hey, I want to come on the mission. We go, oh, yeah, you're good, you can come. So that's probably the best tip I can give you. We have a lot of people that just go, hey, I want to go to Peru with you. Of course, everybody wants to go to Peru. But the students that end up coming with us are the ones that sort of start working for us over here and then come over there with us. Thank you guys very much.